Good morning, everybody, and thank you. I thank organizers for calling me to take or participate actively in this part of symposium, that is to say a few words about community-acquired pneumonia. I feel reasons for choosing or selecting this theme for this conference. Number one, it is a very common problem throughout the childhood with very high rate of mortality. Number two, there is a considerable variation among children in clinical course of CAP, even if the infection is caused by the same pathogen. Number three, the pathogens change with the change of age. Before 6 months, different pathogens, till 4 years, different pathogens. And number two, every child has got different response to the treatment for community-acquired pneumonia. And in next 20 minutes, I will try to address the practical issues faced by pediatricians in tackling the CAP, that is community-acquired pneumonia. So let us start with the first case. I will take 3 examples or ideal cases. This is the first case, a 13-year-old male child admitted with high fever with chills for 2 days. He had cough which was productive with blood-tinged sputum, very severe headache. The child was on summer vacation and returned just 2 days prior to this presentation. There was no history of prior respiratory symptoms or ill contacts. On our examination, child had a high temperature, pulse rate was normal, respiratory rate was normal, blood pressure was normal, and only clinical finding was shower of crepitations on left side with normal cardiovascular system, abdominal examination, CNS system, and hemoglobin was normal. WBC showed polymorphonuclear leukocytes. Platelets normal, electrolytes, blood sugar, all investigations were normal, and the X-ray chest showed left upper lobe pneumonic consolidation. The blood culture which was sent in the hospital ward, it was negative, but the sputum culture, sputum gram stain and culture showed streptococcus pneumonia. So the diagnosis was very evident. It was a lower respiratory tract infection, that is community-acquired pneumonia, with the acute onset of fever, productive cough, left upper lobe consolidation. So with this case, let us think, what is community-acquired pneumonia? Why this terminology? It suggests 4 things. Number one, it is an infective inflammation of the lungs acquired outside the hospital or outside a long-term care facility. Number two, any child which is admitted with signs and symptoms of pneumonia or lower respiratory tract infection and develops new pulmonary infiltrates within 72 hours of admission can be called as CAP. It is assumed that the infection is in an immunologically competent healthy child, though there are certain risk factors or comorbidities which are known to cause more incidence of CAP. And lastly, this term community-acquired pneumonia prompts very speedy consideration what can be the microorganism that is causing the pneumonia, number one. Number two, what is the rational choice of antimicrobial? And number three, which will be the site of management, whether one is going to treat in outpatient, whether the child will be treated in the hospital, whether child will need intensive care unit. So this is the first thing, that what is community-acquired pneumonia and what it suggests. Epidemiology, not very much in details, but it is known that about more than 2 million children die in the whole world due to pneumonia below the age of 5 years. About 155 millions of children get pneumonia in a year, and 80% of them in developing world, while remaining in developed world. So it is very high incidence. Number two, before thinking that it is a community-acquired pneumonia, and diagnosing it, one has to think what are the conditions that mimic community-acquired pneumonia. Number one, acute bronchiolitis, which is very common in early infancy. Number two, any condition which will give rise to congestive heart failure, it will manifest in the same way as pneumonia. Number three, aspiration syndrome secondary to gastroesophageal reflux. They also come with fever. They also come with respiratory embarrassment. They also come with positive signs on auscultation. Number three, hypersensitivity in pneumonitis. And lastly, in an older child, foreign body aspiration. So before labeling the patient that this patient has got CAP, one has to exclude all other conditions. Then the next thing is, what are the risk factors or comorbidities for CAP? Number one, reactive airway disease. Number two, genetic syndromes, neurocognitive syndromes, hematological conditions like sickle cell disease, chronic renal and liver problems. They are all known to increase the incidence of community-acquired pneumonia. So next is, what are the signs and symptoms? The signs and symptoms are same: tachypnea, then recession, diminished expansion, percussion note, dull percussion note, and so on. But over the experience, the community-acquired pneumonia has been seen to be two types: typical CAP and atypical CAP. The clinical features are sudden onset, productive cough, high fever with chills, and respiratory symptoms predominate at the outset with corresponding tachycardia with temperature. And while in atypical, there is a gradual onset, dry cough, fever without chills, constitutional symptoms are present at the outset, and there is a relative bradycardia, though there is temperature. This thing is very important because ultimately one has to manage the case, and with what antimicrobial one is going to manage. So the common pathogens which cause typical CAP are Streptococcus pneumoniae, H. influenzae, pertussis, staphylococci, while atypical CAP, Mycoplasma pneumoniae, Legionella, and viral diseases. X-ray to some extent gives some guidance whether it is a typical or atypical. When you get a lobar consolidation, it is a typical CAP, while if you get the patchy infiltrates, then most probably it is secondary to typical atypical organism. The age incidence below 5 years, typical is more common. After 5 years, atypical is more common. There are certain clinical clues which can give some idea about the microorganism. If there is a nuchal rigidity, hoarseness, erythema nodosum, the Streptococci pneumonia is very commonly seen, while if there is a bullous myringitis, erythema multiforme, Mycoplasma is more commonly associated. Then the next thing one has to decide, okay, we have excluded all the conditions which mimic. We know whether it is typical or atypical. Then the next thing comes whether I am going to manage in the hospital or I am going to manage in the outpatient department. If the oxygen saturation is less than 92% on air, respiratory rate is more than 70 in infants, more than 50 by the age of 1 year, and more than 40 above it. If there is definite presence of chest recession, nasal flaring, difficulty in breathing, and difficulty in feeding, and the patient comes within a little bit dehydrated state, these are all indications that I am not going to treat in outpatient, I am going to treat in the hospital. So one must be sure whether I am going to see. So these are the few questions on the basis of the first case. Let us have second case. It was a 7-year-old girl with G6PD deficiency, signs of viral infections with rhinorrhea, cough for 6 to 8 days without chills, with lots of malaise, myalgia, headache, and history of vomiting. Over next few days, the cough remained same, but ultimately patient got admitted for continuous cough with fever, and at the time of admission, child had red-colored urine or hematuria. On examination, all things were normal. Oxygen saturation was more than 92, and the respiratory system showed scattered crepitations on both sides with normal CVS, normal CNS, normal abdominal examination. On X-ray chest, it showed diffuse bilateral interstitial involvement. On hematology investigation, hemoglobin was slightly on the lower side, but WBC count was normal. Urine showed plenty of RBCs with few WBCs with RBC casts also. And USG showed renomegaly, increased cortical echogenicity. So initially it was a little bit dilemma what I am dealing with, whether it's a G6PD, but there was no icterus, whether it's a IgA nephropathy along with infection, whether there was glomerulonephritis with pneumonia, whether there is a mycoplasma pneumonia, because we sent initially when we saw the child, the cold agglutinins, the child came in the second week of illness, and it showed positive, and mycoplasma IgM was also positive. So what I am dealing with, whether it is a different thing, mycoplasma pneumonia, and the renal problem is different. I excluded SLE, infective endocarditis, hepatitis B, and all those things. Ultimately, we went through the literature, and we got number of cases since 1998, the combination of mycoplasma pneumonia and renal involvement, nephritis, mycoplasma causing nephritis and pneumonia. So this patient had mycoplasma pneumonia, and in addition to it, kidney problem. So we must know what are the causative pathogens which are responsible for CAP. In infants and preschool, it is mainly the viral, respiratory sensitive virus, parainfluenza, influenza virus, adenoviruses, Streptococcus pneumoniae. In school age, the pathogens changed. Mycoplasma pneumonia is more commonly as compared with Streptococcus pneumoniae and viral things. And the Staphylococcus can be there at any time. There is no specific change. There are certain clues in the history which suggest pathogens. If there is exposure to fresh water, or if the child is exposed to the construction site, Legionella is supposed to be very commonly seen. In a closed AC atmosphere in malls and theaters, atypical organisms are more commonly involved. School outbreaks, mycoplasma and Streptococcus pneumoniae and pertussis. Family history of upper respiratory tract infection with fever, viral infection, and you know during 2 years back there were so many cases of H1N1 viral infection. That is seasonal things. In the rainy season, swine flu or viral infections are very commonly seen. So if the patient comes, what investigation one should do? The aims of the investigations to prove the diagnosis that there is pneumonia, you have to do the imaging. Number two, you must know the pathogen, so you have to do microbiologic tests. Microbiologic tests generally are not done in an outpatient department, but if the child is having severe pneumonia, it is admitted in the hospital. Blood culture, sputum, if child is producing sputum, then sputum examination, blood culture, these are the microbiological tests. Then ancillary tests like complete blood count, which we routinely do in a hospitalized patient, but the two important things are C-reactive protein and procalcitonin, which has been already said in the earlier lectures. These two investigations are important from the prognostic point of view. It has been proved that these are increased in bacterial infections as compared with viral infections, and if procalcitonin levels are very high, one should expect that child is going to go in some complication. This procalcitonin gives some prognostic sign. And lastly, pulse oximetry is very essential because we want to decide where we are going to treat the patient. Now this is the third case. It was a 5-year-old child who came with the history of fever for 5 days with respiratory symptoms of cough, sore throat, dyspnea, headache. He had history of headache, loose stools, vomiting, and there was a history of similar illness in elder sibling, which was hospitalized and diagnosed as H1N1 viral infection. So the things were very clear. This patient's X-ray showed right side mid-zone pulmonary infiltrate. This patient was also admitted, and his nasopharyngeal secretions also showed H1N1 antibody. So ultimately, this is one of the example of viral infection giving rise to community acquired pneumonia. In 2009, 2010, we had a lots of cases during the monsoon season of this type of things, and the people were so panicky that any child who gets to cough, they used to land in the consulting room or in the hospital saying that it is swine flu because of this media coverage. But we decided that any child who comes with very high fever, which doesn't come down within 3 to 4 days, which in generally viral infections come down, very bad throat, we used to test for H1N1 and hospitalize the patients. So when a patient comes, we have to think whether it's a bacterial cap or viral cap. If it is an X-ray in bacterial pneumonias, generally we see lobar infiltrates, cavitatory lesions, large pleural effusions, while in viral, you get diffuse radiologic involvement with the exception of H1N1, because we had few cases with pleural effusion with H1N1 infection also. WBC count is very high with bacterial, which is normal in case of viral. CRP is increased in bacterial and it is normal in viral. And clinically, the bacterial, they have got acute onset, fever, cough, chest pain, while in case of viral, there is mainly upper respiratory tract infection to start with and a bit insidious onset. Respiratory system shows signs of consolidation with bacterial, and there are unimpressive clinical features when it is a viral infection. So now we have come to that extent. We have definitely proved it is cap. Number two, we have definitely proved that it is bacterial. If it is bacterial, whether it is typical or atypical. So this is a simple algorithm. If a patient is diagnosed as community acquired pneumonia, whether the comorbidities are present or not present. If they are not present, if the patient is having mild cough, cold, though the X-ray may show the pneumonic infiltrate, we can treat in the outpatient department. As the bacterial organisms are very commonly seen is Streptococcus pneumoniae, the drug of choice is amoxicillin. If we are thinking of atypical, the drug of choice is one of the macrolides or quinolones, or if the child is not responding, we can go up to the cephalosporins. If there are comorbidities, if there is a severe community acquired pneumonia, these patients has to be treated in the hospital. And all those patients we are treating in the outpatient department. If they are not responding, if we are thinking of they are going ahead with some complication, they have to be hospitalized. And once we hospitalized, we have to give supplemental oxygen if they have got very severe community acquired pneumonia, IV fluids to treat the dehydration, correct electrolyte imbalance, never forget syndrome of inappropriate secretion of antidiuretic hormone, because the pulmonary pathology and this particular entity is very often seen together. And third thing is probable choice of antimicrobials. If they come below the age of 1 year, beta-lactam, amoxicillin. If not responding, cefotaxime. If patient is very serious, then both the things can be given as an empirical treatment. If below the 4 years, again the drug of choice is amoxicillin, macrolides. If improvement is not there, one can go ahead with cefotaxime or ceftriaxone. And if a patient comes after the age of 5 to 15 years, the first is azithromycin parenterally or cephalosporins or fluorocorticoids. If there is patient is not responding, lung lesion is not improving, they are getting cavitatory type of pneumonia, one has to keep it in mind staphylococci, where the vancomycin, clindamycin or linezolid, these 3 antibiotics can be given. So this is in short about the management of community acquired pneumonia. What are the recent advances? Recently, there are quite a number of articles about the CRP and procalcitonin, which I already discussed, which is a precursor of calcitonin. It increases in bacterial infection. And if it is continuously increasing with serial things, then it may lead to the complication. We are slowly getting more and more drug-resistant pneumococci. We are very often getting now community-acquired methicillin-resistant Staphylococcus aureus. Generally, this microbe was known to be nosocomial, especially patients who are on ventilator, they used to get this type of infection. But these two, that is nosocomial methicillin-resistant Staphylococci and community-acquired Staphylococci, they are genetically not same. They are genetic setup is different. This community-acquired methicillin-resistant Staphylococcus are known to produce excessive toxins, that is leukocidin, which is known to cause disruptive pneumonitis. Then newer viruses, up till now the viruses were influenza A, influenza B, para-influenza, adenoviruses, but there is a renewed interest in SARS and avian flu. The two more antibiotics are coming on the horizon, that is moxifloxacin and erythromycin. Then one has to think of duration of therapy. If it's outpatient department, 8 to 10 days of oral antibiotic. If it is a hospital patient, it depends upon the course, improvement, complication, depending on that. And lastly, complications. Complications, I have not dealt with complication of parapneumonic effusion, empyema, lung abscess. This patient in complications has to be dealt separately. I think my time is over. I will stop here. This is in short whatever I could say about the community-acquired pneumonia. Thank you.